everyone. Welcome to the Flash Revision YouTube series of Antenatal Care module. I'm Dr. Shamni, your mentor from StudyMEDIC, and I'll be covering the Antenatal Care module most important topics. So let's discuss some SBAs and EMQs. The first question, this is regarding multiple pregnancy. An ultrasound picture shows a twin pregnancy at 14 weeks. What is the best parameter to diagnose chorionicity? So go through the options. Out of all these things, we know the answer and it is going to be E, that is lambda sign. So let's discuss how to determine the chorionicity. So basically you have to see all these factors. One is number of placental mass. Next one is intertwin membrane thickness. So here the membrane thickness, if it's less than 1.8 mm, it is mostly suggestive of monochorionic twins. If it's 1.5 to 2, it is inconclusive. And next one is intertwin membrane placental insertion, which we discussed, and that was T sign for monochorionic pregnancy and lambda or twin peak sign for dichorionic pregnancy. Other one is discordant fetal sex, which indicates a dichorionic pregnancy. This is an update, that is a composite assessment, which has the best accuracy. That is, it means that if you see the placental mass, as well as lambda or T sign in first trimester, that has the highest sensitivity and specificity. So if you get the option with these two, that is the composite method, then you select that. So the next question, a pregnant woman carrying triplets want screening for trisomy 13 and 18. What is the most appropriate screening test? So the answer is going to be D, which is maternal age plus nuchal translucency. We know that in triplet pregnancies, combined biochemical screening is unreliable. So NICE recommends NT plus maternal age only. So this serum screening has high false positive rate, and we have to refer them to the fetal medicine center. So the combined screening is usually done from 11 to 13 plus 6 weeks, CRL between 45 to 84 mm. And the components include maternal age, nuchal translucency, and biochemistry where applicable. So if at all first trimester screening is missed, you are going to offer the second trimester screening, which is the quadruple test. And here are the false positive rate and sensitivity of this test in each singleton, DCD, and MC twins, monochorionic twins. So in singleton, we know that the false positive rate is 2.5%. In DCDA, it is 10%, and in monochorionic, it is comparatively less than that of DCDA, which is 5%. Similarly, for quadruple test also, the sense for singleton, it is 70 to 75% sensitivity, and the false positive is 5%. For both twins, the false positive is 3%. So this is an update in the new guideline that is regarding NIPT or cell-free fetal DNA testing. So it is recommended as a screening method for high risk if at all high risk combined screening becomes positive. That means if at all in twin pregnancies, including monochorionic pregnancies, if this combined screening shows high risk, we are going to offer NIPT or cell-free fetal DNA. It is the latest recommendation. In 2024, they have made this recommendation, and sensitivity for trisomy is around 99%. Now let's discuss the next question. In a twin pregnancy, which fetus should be used to estimate the gestational age? So this is a very simple question, and we all know the answer. It is going to be the larger fetus. In a pregnant woman diagnosed with MCDA twins, at what gestational age should screening for twin-to-twin transfusion be initiated? This is one of the favorite questions of MRCOG, and it is from 16 weeks we have to initiate. So let's discuss the surveillance. So the routine surveillance of monochorionic twins should start from 16 weeks until delivery, and every 2 weeks you are going to do the scanning. And what all are you going to see? You will see the estimated fetal weight, the deep vertical pocket, the umbilical artery PI from 16 weeks, and MCA PSV also from 20 weeks. MCA PSV is from 20 weeks, umbilical artery PI estimated weight and DVP from 16 weeks onwards you have to see. Now, if at all during your surveillance, you are seeing that the DVP difference is more than or equal to 4 centimeter between two sacs, then you have to convert it into weekly screening. That is, weekly scans has to be done. And if at all you come across any quintero stage, you have to refer to FMU. Increased MCA PSV is also an indication to refer to FMU. So let's discuss the next question. Which of the following is recommended to reduce the risk of spontaneous preterm in twin pregnancy? This is a new update in 2024 NICE guideline. So basically, I want to tell you that here we know that twins are at increased risk of preterm labor, and we are going to offer a single cervical length screening at 16 to 20 weeks. And if at all the cervical length is less than or equal to 25 mm, we will be offering vaginal progesterone 200 mg at night. This has to be continued till 34 weeks. Incidentally, short cervix at 20 to 24 weeks also we can offer vaginal progesterone. So don't forget this. Only vaginal progesterone. We should not offer IM progesterone or cervical cerclage or arabin pessary, rest, tocolytics. Nothing is needed. Only vaginal progesterone. So next EMQ we will discuss. So a monochorionic twin pregnancy at 22 weeks shows oligohydramnios in one sac and polyhydramnios in other sac. What is the most likely diagnosis? So you go through all these options. Okay, we know the answer, right? It is going to be TTTS. Next question. A monochorionic pregnancy at 26 weeks. One fetus is showing less than 10th percentile with 30% discordance and normal Leica volume. So it is definitely selective fetal growth restriction. So the answer is B. Next situation. A monochorionic twin pregnancy presents at 30 weeks with intrauterine death of one twin. What is the most appropriate next investigation? It is going to be fetal MRI after 4 weeks. The answer is G. So let's discuss that. So basically, these are the complications of monochorionic pregnancy, that is twin-to-twin transfusion syndrome. It can occur in 15 to 20%. Twin anemia polycythemia sequence, that is TAPS incidence, is usually around 2%, but for TTTS post-laser ablation treatment, the incidence is 13%. So don't forget this. You can get a question from this area. TOPS or twin oligohydramnios polyhydramnios sequence is one complication. TRAP, that is twin reversed arterial perfusion, is another complication. It occurs around in 1%. Selective fetal growth restriction again in 20%, and single intrauterine fetal death and discordant anomalies. So TTTS quintero staging is very important. From each stage, you can get a question. So you have to know the stages. Stage 1 is oligohydramnios in one sac, that is less than DVP less than 2 centimeter in the donor, and polyhydramnios, that is DVP more than 8 centimeter before 20 weeks or more than 10 centimeter after 20 weeks. Donor bladder in this stage is usually visible and Dopplers are normal. Once the bladder is not visible, the donor bladder is not visible, then it becomes stage 2 and there will be severe oligohydramnios. Dopplers can be abnormal but not critically abnormal. That means you're not going to see absent flow or reversed flow in this stage. Okay. So if there is critically abnormal Doppler, it becomes stage 3, which means abnormal umbilical artery Doppler and also abnormal venous Doppler in the recipient, like ductus venous reversal, pulsatile umbilical vein pulsations, all those things will be there. Stage 4 is high drops, that if the baby is developing high drops, that means it is stage 4. Any intrauterine death of any one of the twin becomes stage 5. So selective fetal growth restriction in twins, estimated fetal weight discordance more than 20%, and smaller twin, the estimated fetal weight or abdomen circumference is less than 10th percentile. If at all you come across this situation, what are you going to do? You will be doing weekly ultrasound. Okay. So on doing weekly ultrasound, how will you diagnose selective fetal growth restriction? You can diagnose if the smaller twin estimated fetal weight is less than 3rd percentile. That itself is needed for the diagnosis. Or else, if any of the two of the following is present, which means estimated fetal weight discordance of more than or equal to 25%, if Along with that, any two are positive means you can diagnose. Other two things are both twins. EFW by AC is less than 10th percentile, umbilical artery PI more than 95th percentile, or if there is absent or reversal in the end diastolic flow. So this is how you diagnose. So don't forget, EFW discordance more than 20%, you are going to do only weekly scans. But if it's more than or equal to 25% along with any one of these things, then it becomes selective fetal growth restriction. If you diagnose it, definitely you have to refer to the FMU. So let's discuss the next EMQ. A monochorionic diamniotic twin pregnancy at 19 weeks is diagnosed with Quintero stage 2 TTTS. What is the definitive treatment? So treatment will be covering in detail. So we should understand that less than 26 weeks, it's going to be fetal laser ablation. So the answer is A. Following successful fetoscopic laser ablation for TTTS, what is the recommended ultrasound surveillance after first 2 weeks? So we know that initially for the first 2 weeks, you will be doing weekly ultrasound with Dopplers, and after 2 weeks, you will be doing 2 weekly. So don't get confused here. Here they have asked after 2 weeks. So the answer is going to be E. That is ultrasound every 2 weeks after treatment. A pregnancy treated for TTTS is now stable at 28 weeks. What additional specialist fetal assessment is recommended? This is very important. We have to do a detailed fetal echo because there can be pulmonary stenosis. Around 11% have heart defects like pulmonary stenosis. So let's discuss the management in detail. As I already told you, TTTS less than 26 weeks, the preferred treatment is fetoscopic laser photocoagulation. And if it's more than or equal to 26 weeks, it is going to be an individualized management. So don't say it is amnio reduction always. It is going to be an individualized management. It depends on many factors. There can be expectant management, amnio reduction. Sometimes if the fetus is so much compromised and if it's advanced gestation, you are going to deliver the baby. So laser therapy generally not the first line after 26 weeks, but in exceptional circumstances, we may consider. So the technique is very important. The fetoscopic laser ablation technique, you have to remember these terms. That is, it is done using serial sequential technique. Then after that, equatorial laser dichorionization should be there. So remember these terms, and it is called as a Solomon technique. And the center should be performing more than or equal to 15 procedures per year, rolling for 3-year average. And post-treatment, as I already told, weekly you have to do the scanning for first 2 weeks. You have to see for the fetal brain, heart, limbs, umbilical artery PI, MCA, PSV, and ductus venosus Doppler. If everything is good and fine, then you convert into 2 weekly follow-up. So you have to document again umbilical artery PA, and also MCA, PSV, ductus venosus, DVP, and also the growth. So the fetal echocardiography, we already discussed that it is done by the fetal medicine specialist because 11% risk is there for cardiac anomalies like pulmonary stenosis. So let's discuss this EMQ. A monochorionic twin pregnancy has single intrauterine fetal demise at 26 weeks. What investigation should be planned to assess the neurological injury? We have already discussed this before. It is going to be a fetal brain MRI after 4 weeks. In the same pregnancy, which Doppler is used to detect fetal anemia? You know that it is going to be the MCA PSV Doppler C. Option C is the answer. Now, next is a monochorionic twin pregnancy with single twin demise remains stable. What is the recommended delivery time? If no complication develop, it is going to be 36 weeks plus 6 days if at all no complication develop. So regarding single intrauterine death of one of the twin, the risk to the surviving twin, these numbers are very important. Death incidence is 15% and neurological abnormality risk is around 26%. They can come as SBAs, and this has to be managed in a fetal medicine center. MDT should be there, and fetal brain MRI, as we already discussed, should be performed 4 weeks after the demise. And regular ultrasound surveillance should be there. We have to also screen for fetal anemia using MCA PSV. This table is very important. You will get questions from each and every box here. Delivery timing. Uncomplicated DCDA twin, you are going to deliver at 37 weeks. Uncomplicated MCDA at 36 weeks. Uncomplicated triplets, trichorionic triamniotic twins, you will deliver at 35 weeks. Treated TTTS, here again there is a change in the new update. It is going to be 36 weeks according to the new update. Monochorionic monoamniotic twins, because of the cord entanglement risk, we are going to deliver at 32 to 34 weeks, and definitely it is going by, we'll be doing it by cesarean section. So this we already discussed, the single twin demise, it's 36 plus 6. If it is type 1 selective fetal growth restriction, 34 to 35 weeks, and type 2 and 3, it is 32 weeks. Okay. So that's all regarding multiple pregnancy. Let's discuss the second topic, the Rh negative pregnancy and red cell antibodies. So this table is important. That means for all the pregnant ladies, you are going to do at the booking ABO-RH typing as well as antibody screening. So if during that period, if at all you come across any clinically significant antibody screen positive, that is, if at all patient is positive for anti-D, C or K antibodies, what you have to do? You have to test monthly for 28 weeks, and after that every 2 weekly till delivery. Okay. Now, if at all other clinically significant, other than this, other clinically significant antibodies are there, that means you may consider either paternal testing or fetal genotyping, and you are going to repeat at 28 weeks only. So at booking and 28 weeks only for others. If at all you don't see any antibodies, you will repeat again at 28 weeks. So this is very important. Anti-D, anti-C and anti-K are supposed to be very severe. Anti-K, even in low titer, it is considered to be very severe. And you should understand that anti-E increases the severity of anti-C disease. So when you have to refer to FMU, when the anti-D, it becomes more than 4 international units per ml, anti-C more than 7.5. So anti-D is severe if it is more than 15 international units per ml, but you will refer if it's more than 4. Anti-C becomes severe if it's more than 20, but you are going to refer if it's more than 7.5. Anti-K, any titer, you just refer. Other antibodies, if the titer is more than or equal to 32, or if the patient gives severe history, previous history of any hemolytic disease of newborn or intrauterine transfusion, then you have to refer. So this is how you are going to approach your patients. If at all anti-K antibodies are there, we already told. So either you can consider cell-free fetal DNA or non-invasive prenatal diagnosis, or you can test the father. If the father is tested homozygous, definitely the baby is at risk. If the father is heterozygous, then you have to understand whether the baby is positive or negative. So you have to do cell-free fetal DNA. If the baby is negative, nothing to do. Positive means baby is at risk. So similarly, in all other antibodies levels we have already discussed. So if the fetus is at risk, what you have to do? We have to refer to the specialist. We discussed at what titers you will be referring to the specialist. Refer the specialist. We have to do a detailed ultrasound, and MCA Doppler should be done frequently. 1 to 2 weekly it has to be done to see whether the baby is developing anemia or not. If at all baby develops anemia and it is early gestation, means you are going to do intrauterine transfusion. If it's around 34 weeks, you can deliver. So if at all everything remains stable, baby is all okay, then you may consider delivery at 37 weeks. And after delivery, you have to advise cord blood, hemoglobin, bilirubin, and direct antiglobulin test for the baby. So blood for intrauterine transfusion, it should be group negative for corresponding antigens, K negative, CMV negative, and irradiated, and less than 5 days old. The hematocrit should be 0.7 to 0.85. The delivery we already discussed. General approaches, if everything remains stable, 37 to 38 weeks, and continuous CTG is recommended during labor. And if at all it's a high risk cases like placenta previa where large transfusion is expected, we have to deliver at a center where there is rapid compatible blood access. Let's discuss some questions. Anti-K antibodies detected at booking. Titers are very low. You know, we have to refer to the fetal medicine immediately. Which Doppler best predicts fetal anemia? We already discussed MCA-PSV. A woman has anti-D of 18. So that means it is more. At 26 weeks, the interpretation, it is severe. So the fetus is at high risk for hemolytic disease of newborn. Next is Rh negative women. Previously had normal antibody levels. During monitoring at 36 weeks, anti-D is found to be 16, which means it is high. She delivers at 37 weeks. Her baby could develop which of the following? Okay, because it is very high, baby may develop early jaundice. Timing of delivery of a woman with anti-K antibodies that remain low throughout pregnancy without any complication, we already discussed, it is going to be 37 to 38 weeks. If Rh negative women undergo cesarean section with intraoperative cell salvage, what is the appropriate dose of anti-D to be given? The dose of anti-D is very important. Almost always you will get a question from this, and here the answer is 1500 plus FMH should be done 30 to 40 minutes after transfusion. So give anti-D as soon as possible within 72 hours or within 72 hours, regardless of the gestation. So in many cases. So here, this is according to the older guideline, that is termination if it's medical or surgical. Now, according to the NICE guideline, there is a change, which we will be discussing. So miscarriage or incomplete miscarriage more than or equal to 12 weeks, definitely you have to give. Any uterine evacuation, again, there is a change. More than 12 weeks, you are supposed to give. Ectopic, antepartum hemorrhage, amniocentesis, CVS, fetal blood sampling, chordosynthesis, or any versions, closed abdominal injury, intrauterine fetal death, or stillbirth, you have to give. Ideally, within 72 hours, even if it has passed, you can give because it has some action in 10 days. So this table is very important. So first, the spontaneous miscarriage less than 12 weeks, there is no need. Medical or surgical miscarriage less than 12 weeks. Earlier they used to say 250, but now according to the NICE guideline, less than 12 weeks, no anti-D is needed, irrespective of whether it's spontaneous, surgical, medical, whatever it is. Ectopic less than 20 weeks, you have to give 250. More than or equal to 20 weeks, 500. So if it's 20 weeks, means you have to give 500. And you have to do FMH testing also. Routine antenatal anti-D prophylaxis, you know, we usually give it 28 weeks, 1500, or we may give it as divided like 28 and 34, 500 plus 500 you may give. Now, next is, and here for routine, we are not going to do the FMH testing. IUD, this is a very important thing. When will you give anti-D? You have to give at diagnosis of IUD, not after delivery. Just remember that. So this is also important. That is, post-delivery, we already discussed, you're going to give 500 units and FMH test is mandatory. Rh negative women, if they receive Rh positive platelets, 5 adult doses if they receive, you have to give 250 units, international units within 6 weeks. And if there is an inadvertent transfusion of RBC, if it's less than 15 ml Rh positive red cells, for this, we have to calculate like this. We have to give 500 units covers 4 ml. 125 units per ml we have to give IM anti-D. If it's more than 15 ml Rh positive red cells, we have to give 1500 to 2500. Usually IV is preferred here because you are more than 15 ml is there. More than or equal to 1 unit means we have to consider exchange transfusion. So let's discuss some questions. EMQ, a 12-week pregnant patient is found to have anti-D antibodies and partner is heterozygous. So what you have to do, partner is heterozygous. So we have to find out whether the baby is having positive or not. So you have to do cell-free fetal DNA. 22-week pregnant woman has anti-D12, but partner is homozygous. So anti-D is more, partner is homozygous, definitely baby is going to get affected. So how we have to monitor? We have to monitor by MCA-PSP. So it is not fetal medicine referral, because fetal medicine you would have already referred once it becomes more than 4, right? So if it becomes 12, then you have to do MCA-PSP monitoring. Anti-K antibodies detected at booking? Yes, you have to refer to fetal medicine, even if the titer is low. Next question. Select the most appropriate option. MCA-PSV is 1.6 mom at 26 weeks. That means it is more. So what you have to do? We have to refer for intrauterine transfusion. Babies having fetal anemia. Anti-D positive women, MCA-PSV 1.2 mm. So here we have to monitor only. So we have to do weekly MCA-PSV. Anti-D positive, MCA-PSV more than 1.5, 35 weeks. The patient has already become 35 weeks. So what you will do? You will usually deliver. Anti-K antibodies, low titers and no complications. So you are going to deliver 37 to 38 weeks. We already discussed this. Post intrauterine transfusion pregnancy with stable MCA. So here 36 weeks post intrauterine transfusion. 36 weeks. Rising titers with abnormal Doppler at 35 weeks. Here the answer is immediate delivery. So select the most appropriate option. One is Rh negative women with APH at 24 weeks. Definitely you are going to give 500 international units, because 24 weeks, more than 20 weeks. And you have to do an FMH testing also. IUD diagnosed, no fetal blood, you have to give 500 international units. And severe thrombocytopenia. So here you can't give IM. So you can give either subcutaneous or IV. Baby born to mother with anti-D 16.5 at 36 weeks. So they have early jaundice. Baby treated antenatally with multiple intrauterine transfusions may have late anemia. So you have to follow up the baby. Baby with positive DAT but normal bilirubin at birth may also have late anemia. So you have to follow up the baby. So let's discuss the next topic, which is genetics. So basically the important conditions are, one is Down syndrome. We know that the most common trisomy, which is trisomy 21, Edwards is trisomy 18, the second most common autosomal trisomy, then is Patau's. These all may come as questions. The most common chromosomal abnormalities in aborted fetuses usually Turner syndrome first, then triploidy and trisomy 16. So Down syndrome features are very important. Mostly it occurs due to non-disjunction, 95% of the cases. In familial Downs, usually Robertsonian translocation is seen. And these are the features of Down syndrome, where there is flat occiput, slanting eyes, short nose, broad hands, hypertonia. Congenital heart disease, especially ABST, is common here. Edwards syndrome, all these may come as questions. The rocker bottom feet, overlapping fingers, clenched fist, IUGR, hypoplastic nasal LA, then cardiac defects like VST is the most common. So Patau's is also very important. 90% due to non-disjunction only. The ultrasound findings of Patau's usually include hollow prosencephaly, agenesis of corpus callosum, polydactyly, hypoplastic left heart, renal cyst, severe growth restriction. And 7 P's of Patau, like hollow prosencephaly, cleft lip palate, polydactyly, pump disease, polycystic kidney. And this is also very important in genetics, like Dijot syndrome is 22q11 maternal deletion, Angelman syndrome, and Prader-Willi syndrome. And the features of all these 3 things are important. So this is a box. This definitely you will get a question from this. Autosomal recessive disorders. The mnemonic is A, B, C, D, E, F, G, H, I. ataxia, telangiectasia, albinism, alkaptonuria, beta thalassemia, sickle cell anemia, cystic fibrosis, CAH, deafness, emphysema, Friedreich's ataxia, Gaucher disease, galactosemia, GSD, homocystinuria, hemochromatosis, and other inborn errors of metabolism like PKU and lysosomal storage disease. So here, basically in autosomal disease, recessive 25% will be affected, 50% carriers, and 25% will be normal. Like that, autosomal dominant disorders are also there. The heavy dominant is the mnemonic, and these are the examples for autosomal dominant. And affected parent, 50% risk to each child will be there. So we have to by heart this, and we have to see how it is going to be inherited. X-linked recessive mnemonic is girls don't care for chawal. So these are the disorders in X-linked recessive. So X-linked dominant also the mnemonic is ARCH, that is Alport, Ricketts and Rett syndrome, and also Charcot-Marie tooth disease type X. Mitochondrial inheritance is Leber, Hedrick, optic atrophy and Leak syndrome. So let's discuss some important questions of this. So a couple presents for genetic counseling, both the mother and father are carriers for cystic fibrosis. They are concerned about their offspring. So what is the likelihood of their child getting this? So we know the answer, it is autosomal recessive. So 25% will be affected. So the answer is F. Two men who met in a support group have both CAH. One man's son marries the other man's daughter. In the offspring of this couple, what is the risk of inheritance? We know that it is autosomal recessive, but here the answer is going to be C because we don't have enough data. Although both grandfathers are affected, the carrier status of the son and daughter is not known. So without knowing that, we won't be able to see the risk. Third question, a couple seeks genetic counseling regarding the Down syndrome in their unborn child. Mother is 35-year-old. What is the most accurate statement of inheritance? We know that it is non-disjunction. Mostly 95% is like that. Father has Duchenne muscular dystrophy. Mother is unaffected. What is the most common inheritance? So here the answer is going to be C because we know that it is going to be X-linked recessive. So if the affected father plus normal mother, so sons receive Y from father will be unaffected. Daughters will receive the affected X and all will be carriers. A male child has G6PD deficiency. Mother is unaffected. What is the inheritance pattern? So answer is C, X-linked recessive. This is EMQ. So 28-year-old woman undergoes a second trimester anomaly scan. Fetus shows hollow. You know the answer, holoprosencephaly, cleft lip, palate, polydactyly, 7 Ps. It is Patau syndrome. A neonate has rocker bottom foot, overlapping fingers, clenched fist, prominent occiput, and severe cardiac defects. Answer is Edwards. And products of conceptus, abortus, most common is Turnus. A couple has 2 children with Down. Mother is phenotypically normal, but carries a chromosomal rearrangement. So here the first question is, so for this the answer is Robertsonian translocation. And for the first question, 36-year-old woman delivers a baby with Down syndrome, no family history, and parental karyotypes are normal. So it is going to be non-disjunction. We already discussed this before. A child has milder intellectual disability and fewer dysmorphic features than typical Downs. Karyotype is showing 2 lines. So it is mosaicism, probably. Next question is, a couple are carriers of cystic fibrosis. They ask about the risk to their next child. We know cystic fibrosis, it is autosomal recessive. Marfan syndrome is autosomal dominant. And so the next question is, a woman affected with Leber, Hedrick, optic neuropathy. So it's a mitochondrial disease. So it is mitochondrial inheritance. Answer is E. So again, a boy presents with progressive proximal muscle weakness, raised CK, and loss of ambulation. So it is Duchenne muscular dystrophy. A male child developing hemolysis after anti-malarial drugs, definitely G6PD deficiency. Answer is C. And girl develops normal early development followed by regression, loss of speech and stereotypic hand movements, typical of Rett syndrome. 30-year-old woman at 11 plus 5 weeks want the best non-invasive screening for trisomy. It is cell-free fetal DNA. It has 99%. It is best. Okay, so best is 99% NIPT. A woman at 18 weeks has not had any first trimester screening. Wants biochemical screening. Now you may offer quadruple test. Next is screening test is showing 1 in 100 risk for Down syndrome. So it is high risk. We have to refer for prenatal investigation, that is amniocentesis. So that's all regarding the antenatal care module. Thanks a lot. All the best for your exam. Do well.